Okay, and the best is now going to be the best, I hope.
Apologies for the delay. I don't know how did I end up giving unreasonable timing for the slides. Okay, so we're done there. Okay, so standardization basically it means there's consensus between firms, users, interest groups, standards organizations, and governments. The reason why I put firms first, we'll see later. And basically, you try to figure out one single best way. And the rationale behind standardization is basically safety of the patients, reduction of complications, uniformity, be it in terms of management as well as the outcome, and also to have some form of evolution, because when everybody is very coherent with one particular method, then they would start to innovate. And of course, training and reproducibility. So now we come to something which is a bit more controversial. So how do we come with this standardization? It's basically by a taxonomy whereby we come up with the guidelines, protocols, apply, we see them on cases, feedback, and revise. However, when we talk about developing or LMIC countries, this bit, we do not have the control. It's usually dictated by the authors who are from developed countries. And again, this is quite redundant actually. So US Institute of Medicine defines guidelines as statements that include recommendations intended to optimize patient care with systematic review of evidence and assessment of benefits, harms of alternative care options. So it is intended to provide a source of best evidence that can be integrated with clinical expertise and experience and patient preference to informed clinician as well as patient decision making. So I would like to highlight here informed clinician decision making, because quite a time I have come across personally, people quote guidelines without themselves having a clear, coherent understanding of it. That is where the issue comes about. And well, generally they use frequency-based reasoning. You take a big cohort and you try to fit in for one person. So usually what happens for a big cohort may not necessarily be beneficial for those individual patients. How? Because our day-to-day practice, we do not see a homogeneous population. What we see is a very heterogeneous population. When you talk about randomized controlled trials and all, we always try to get them as homogeneous as possible. And some people, they would actually go on with adapting this or utilizing these clinical guidelines without proper clinical judgment or adaptation to individual needs. That's where the issue comes about as well. And again, guidelines usually concentrate on single disease entities. So imagine if the person has got road traffic accident with head trauma, pelvic fracture. On top of it, you give the person a diabetic ketoacidosis. So which protocol is going to take precedence? Now, and I found this interesting article which was published, I would say rather recently in 2018. Now, they talk about prevalence of financial conflicts of interest among authors of clinical guidelines related to high revenue medications. Now, this is not for neurosurgical cases. These are for gastroenterology cases. However, I'm making a presumption that it would apply rather similarly as well. So now about half of them, actually, half of the authors declared potential financial interest, and about 25% actually did not declare their financial interests. And another study whereby they talk about the review of industry funding, they actually found the odds ratio of 23.5 between those who are not funded and those who are funded by industry. So something must be wrong somewhere. And they did also mention that multiple authors was mildly protective with the odds ratio of 0.79. So again, another paper whereby they mentioned the similar thing, but here the odds ratio was a bit smaller at 10. And let's just go a bit into spine implants. Now, the spine implants and devices industry are worth approximately 8 billion US dollars in the US alone in 2014, and they expect it to rise to 16 billion by 2020. And out of these cases which are implanted, about 20% are expected to have failed back surgery syndrome. And then what happens is, not only they sell us implants, which do not really help the patients, and then they sell us implants again to overcome or to try to overcome the issues which were caused. And for hospitals, well, they're not angels either. In 2004, 16 billion US dollars was in hospital charges. And this table here basically shows 8 randomized controlled trials with regards to efficacy of spinal cord stimulation done rather recently, and none of them actually are devoid of any form of industry influence. Most of them are funded. The only one which they did not report whether they're funded or not, the consultants are paid for by the companies, and an employee of the company was also involved in interpretation of the data. And something very I would like to highlight is between 1999 and 2010, one single company paid out about 210 million US dollars to physicians, authors for consulting royalty. And in that case, one physician alone received $34 million in that period, of which $5 million was just for one single year. So he's got a bumper harvest there. This, I believe, is redundant already. It's just reflecting upon what I mentioned earlier. But the rate of industry-funded studies which are being published are increasing year to year. Now, something which I really have in heart, accessibility. Now, the governments, they tend to, as what was mentioned earlier, they tend to talk about financial feasibility of things. Now, protracted transport times and lack of resource training and difficulty in retaining specialists are barriers to successful outcomes. Now, this was published in Current State of Neurosurgical Praxis. And a large proportion of rural patients die before reaching advanced medical care. Why I'm highlighting advanced medical care here is, at times there's no necessity for us to have advanced medical care. Just basic medical care is adequate. We do not need to have ICU in, let's say, Chitral, whereby the population, I'm not sure what's the population, let's throw a figure of 1,000. It obviously does not make any cost effectiveness, but what about putting basic craniotomy sets? And if they have a CT scan, that's good. And this is really interesting. The drug lobby in 2018, a total of 3.4 billion US dollars was declared as lobby expenditure, of which 0.79 billion was by the medical industry complex. Now, if you notice here, the much touted defense industry complex is nowhere in the list. They are way low down. And the top 3 medical companies, they spent at least 6 million US dollars in 2018 for lobby expenses alone. And this is what is declared. What more those which are not declared? And if you take this $709 million and you compare it with other countries, it would actually be the 176th largest governmental budget. It is it's much larger than the budget of Bhutan. However, each year about 100 million people slide into poverty as a result of medical care payments. This was it's actually quite old data, but I'm assuming it's still relevant. And 150 million people are forced to spend nearly half their incomes on medical expenses. Now, imagine if you are, or if the person is leading a hand-to-mouth existence and they need to pay. Or let's say that they're just barely making it, they need to pay. And this burden would actually carry forward. And I remember reading an article before coming here. In Pakistan, that's a real issue, especially when it comes to bonded labor. I'm not sure whether it's an exaggeration by the Western media, but that is what I read. And if you look at self-payment, a developed country, which is Germany, only 10% of the GDP was being out-of-pocket expenditure, whereas for Congo, 70%. And mind you, the GDP in Congo in 2005 was only $120. Okay, now the reason why I chose this topic was actually because of Randall here. I was in another developing country and I was chatting and they said that, hey, I do ICP monitoring. Okay, I was excited. So, and then I asked them, in which selection of patients you do ICP monitoring? Oh, we do them on all patients with a GCS of less than 12. I may be exaggerating, but I may sound exaggerating, but it's the fact. And so I asked them, so do you intubate and nurse them in ICU? No, we do not have ICU beds. So imagine someone with a bolt sticking into the parenchyma and thrashing about. Do we think we'll be able to get ICP control? I don't think so. Yep. But, sorry. So often they quote this particular slide. However, they miss this slide. They quote Randall telling that he advocates ICP, but they fail to realize if ICP monitoring is not available, aggressive protocolized care can lead to good outcomes. And he does not advocate ICP monitoring in cases where basic ICU care is not available. So again, it falls back to the understanding of the physicians involved as well. It's not only the industry complex, it is not only the government's, it is everybody's responsibility. So I am not of a position to give any recommendations. However, I'll share what I think I can do. I can strive for equitable access to basic neurosurgical care, which is by advocacy, probably what I'm doing now. Volunteerism, if there's any opportunity, I would go. Be fair in judging or criticizing my peers who work in resource limited environments. I believe this is very important because very often at times we compare ourselves with them without putting ourselves in their shoes. And of course, being innovative or adaptive and judicious use of technology, right? Just because we have it doesn't mean that we have to use it. If we can get away without it and reduce the burden of medical bankruptcy, if I may put it, why not? And in my practice, very often, I hardly use any adjuncts for my craniectomies, and I believe my outcome is similar, if not better, than my colleagues. Guidelines, yes, they are important, but they have to be subject to local limitations. They should not be blindly followed. And of course, I need to remember who I owe my duty to, which is to the patients. So why do I think there should be a paradigm shift? Guidelines should be devoid of conflict of interest. It should be holistic. It should recognize heterogeneity. It should take into consideration viability to caretakers. And we need to recognize the limitations of different geographical or socio-economical sites. And most importantly, we need to understand the guidelines and available evidence. So in conclusion, access to healthcare is a basic human need. It must be made the right of every human to obtain equitable, safe, accessible healthcare as per local limitations. And standards must take into account, again, I'm just repeating myself, and more resources need to be placed to improve basic healthcare to the underserved. There is no point for us to go and get a 3 Tesla intraoperative MRI, whereas basic equipments are lacking. This is something which I saw 2 days back. It's very interesting. Fake facts and alternative truths to medical research. So forget about the fake, but they say that scientists appear to engage in facting interest instead of revealing interesting facts. And this leads to polarized research. So if I keep repeating the same thing over and over again, there's one point in time where whatever I'm researching would be positive. All right. Science is built of facts the way a house is built of bricks, but an accumulation of facts is no more science than a pile of bricks. It is a house. Thank you.